All right, everyone. So we'll go and get started on chapter 23. This is over toxicology. Interestingly, we actually run a lot of calls on toxicology. People overdose, right? First, you should know that children put everything in their mouth, right? So they'll end up putting batteries and medicine and all sorts of stuff, plants in their mouth. But oddly enough, humans take it a step further. They not only put everything in their mouth, they'll smoke it, snort it, inject it, put it in their rectum, vagina, whatever. And so, you see a lot of toxicology, whether it's intentional or not. A lot of times it is intentional, sometimes it's unintentional. We see a lot of this. And in fact, I'll say the overdoses, like especially intentional overdoses, really any overdose, are some of my least favorite calls to run because they're very complicated. You usually don't know the true extent of what they did or didn't take, or you don't know the whole story, and so your treatment becomes really uh, of course you just support their care, but it just becomes difficult. I just don't like running overdoses, but we run a lot of them. We run a whole lot of overdoses. And so as we work through this chapter, you'll be like, oh, wow, you've covered some of this in pharmacology. I have. And the fact that I've covered it in pharmacology should make you realize this is important. They want you to actually know this. So some of this will be a review, some of it will be new. So without much less to say, let's get started. So, a poison is toxic by nature. That's kind of intuitive, but a drug can have a physiologic effect if given in appropriate circumstances and dose, right? Overdose is a toxicological emergency. So we see this a lot. And like I alluded to earlier, overdoses aren't always intentional. Sometimes they're unintentional. Sometimes the patient didn't realize, or they doubled up on their medicine, or they didn't take off their fentanyl patch before putting a new one on, or something like that. Or whatever. The way the doctor didn't prescribe it properly, or whatever happened. But just realize that overdoses tend to be intentional, but they most certainly can be unintentional. And really, it's not always important for us to figure out if it was intentional or not. But that does play a role. As a reminder, if someone intentionally overdoses to cause self harm, then you have to worry about the risk of suicide. If are they trying to commit suicide or self harm, especially because then you don't have the rights of refusal, right? So if someone is alert and oriented times four, right? They're totally alert and perfect, but they just told you they took 100 Tylenol tablets to try to kill themselves, but they don't want to go to the hospital. Can they refuse? No, they cannot refuse, right? Because they don't have the right to refuse at that point. They're suicidal. So remember, suicidal and homicidal people don't have the right to refuse medical care because they're not, they're not in the right state of mind. Now, with that, you want to ensure your safety. You'd probably in Texas, especially, have to involve law enforcement in that, to where they would do what's called a medical detention or apprehension. I'm sorry, it's a medical apprehension. And so basically, they'll kind of place them underneath this like pseudo arrest where they don't have a choice, and they'll end up going to the hospital. Usually, you'll stay there for at least 3 days if you try to kill yourself. So, anyways, just be aware that that's Texas's laws. I'm just letting you know, like for when you start working on the street, it varies state to state. It's a big deal to take away someone's rights. Okay, so that's why there's rules that vary from state to state. Now, toxicology, you remember the word ology means the study of, so this toxicology is the study of toxic or poisonous substances. So I just alluded to this. Some are intentional, some are unintentional. Remember, unintentional overdoses cannot refuse care, or intentional overdoses cannot refuse care usually. Can be found in nature and workplace. We'll talk about this. Can be from neglect and or lack of oversight. This happens with physicians, unfortunately, a lot. We'll prescribe the wrong dose, or we didn't check to see all the medicines they're taking. So you can have this thing called potentiation, where, like potentiation is 1 plus 1 equals 4, right? So you get a little morphine, but they're already taking like all these other drugs. And so instead of being 1 plus 1 equals 2, it's going to equal 4. And so they end up overdosing. And so this actually happens quite often. And it's the risk of prescribing and treating. So this is why it's important to know your patient's history before doing that. So it can be intentional. Of course, there's biological warfare weapons and date rape drugs like Rufinol and GHB and even ketamine and Xanax and all that stuff. But we'll talk about that. We'll talk about biological warfare more so. There's an entire chapter dedicated to terrorism. And so we'll talk about that more and the agents they use. But yeah, of course you can. This is the Gulf War especially. Well, really, a lot of wars we've used biological warfare. Hey, I mean, yeah, never mind. I won't talk about that. So there's this thing. You don't need to memorize this number for a test, but it is an easy number to memorize. 1-800-222-12222. All you got to remember is two. There's a lawyer down here in South Texas that has fours, and so that's his slogan. But um, so this is the poison control hotline. It's free. It's available 24/7. If you grew up in the 90s, you had one of these on your refrigerator, guaranteed. They're like little magnets. And so I've actually called the poison control hotline several times. You'll just call them, and there's like an expert on the other end of the line that'll talk you through the exposure and the proper treatment and recommendations. In the hospital, especially at Cook Children's, we used to call them all the time. Even if we knew the treatment, it was like the standard of care and like the protocol there that we would still notify the poison control hotline. And so that was the standard. So you could call these people, and I've called them in an ambulance before too. I don't remember the exact scenario, but I have called them in an ambulance. I don't remember the scenario, but anyways, I've done it. So just be aware that's available, and so they can help you out. You don't have to memorize the number, but it's a good number to know. Now, toxins can enter the body in a variety of ways, but you need to know these routes, right? This will show up where you'll need to know, like, oh, your patient ingested fentanyl. What does that mean? That means they ate it. So ingestion means to digest, to eat, right? So they ingested. You can inhale, so you can snort it. You could just breathe in chlorine in the air, or it's carbon monoxide. Those are so snorting and just straight up inhaling are, obviously through the nose or through the mouth. You could suck it in as well. Injection. So this is kind of obvious. This is using parenteral route. Parenteral means through the skin. Like injected through the skin, and then absorption is this. This could actually happen. This happens often with fertilizers and something called organophosphates. We'll talk about these, but this is a big concern. Okay, absorption go through your skin. Nitroglycerin can go through your skin. There's a lot of stuff that can go through your skin, but not fentanyl. Fentanyl doesn't travel through your skin. Well, it doesn't normally travel through your skin. We'll talk about that. Now, effects of an excretion rate are determined by the amount of toxin and the speed of metabolizing it. So, the excretion rate is how quick does your body get rid of something, okay? And typically, almost always, everything is excreted through the kidneys, and then it goes out through your urine. That's the most common route, like medicines and stuff. That's usually how we get rid of it. But you should be aware that you can actually sweat some stuff out, so it can travel back through your skin. You can breathe stuff out. That's a very common route, especially for inhaled gases, but actually alcohol as well. This is why you have alcohol in your breath when you drink alcohol, is because it's excreted through your lungs. One of the many ways we get rid of alcohol. So yeah, just be aware that, and this is intuitive, right? The more stuff that you ingest or take in, that'll affect the amount of the toxin will affect the speed of how quick you can metabolize it. So let me actually draw this metabolism thing out. So, whoops, this is supposed to be like a graph, right? Okay, and it doesn't look like one. You get it. There's an X, y-axis. Okay, and my Y looks like a X. Okay, so let me just give you an example. The liver can, let's just act like this is alcohol, can process alcohol up to an imaginary rate, okay? But what happens is when you drink more alcohol than what your body can process, you get drunk and you get the effects of alcohol. So this is very common. It doesn't matter if we're talking about alcohol or a lot of other drugs. Your body can metabolize a portion of it up until it can't, and this is where you get intoxication and start getting into like the more extreme effects of a medication or a toxin. So just be aware of that. Now, poisoning by ingestion, again, this is by mouth, by the boca, the mouth, right? So most common sources, medications around the home. You'll see this a lot in vignettes. Little kid got in grandma's purse, ate all her medicines, right? And so you're like, oh, okay, yeah, that's an ingestion, okay? This is probably one of the most common ways this happens. Household chemicals, again, you hear this a lot. Little kid got up underneath the sink, started drinking bathroom tub cleaner. Why? I don't know. But I'm just saying you'll see that in like a vignette or something like that. Little kid drank antifreeze. It's actually a sweet taste to it, so you'll see that as well. It's rather lethal. Effects can be immediate or delayed. It depends, right? So like alcohol is almost immediately absorbed versus if it's a pill, it could take a long time to absorb and show its effects. So it depends on what it was that they ingested. This is where we become little detectives and we got to figure out exactly what they did and didn't take. And then the entry of toxin by oral route takes longer to be absorbed by the body. So this is probably versus like injecting or inhaling or absorption, this is probably the longest route because the unpredictability of the substance that's being taken, some of it's immediately absorbed in the stomach, some of it has to be absorbed throughout the very end of the intestine and the ileum. It really kind of depends on what you took. Okay. Now, some EMS systems, and even though EMTs use these, I don't know a system that carries this anymore, but it is commonly tested. This is tested. You will see this on an exam. Carries something called activated charcoal. Yes, literally the charcoal that you would put in your grill. It has been smushed into a powder. And the interesting thing about charcoal is it has a tremendous surface area, huge surface area. And so what happens is when a patient is treated with activated charcoal, they'll drink it, the activated charcoal, and it will bind to whatever's in their intestines and in their stomach. And since it has such a large surface area, it coats it to where it can't be further digested. And so it binds to poison and it carries it out of the system because there's this huge surface area. And so that's the idea of activated charcoal. The dose is about 1 gram per kilogram of body weight. And so we'll talk about, there's slides coming up with when you can and can't use this. But as far as EMTs are concerned, this is usually the antidote. Like I said, I don't know any ambulances that carry this, at least that I've worked on anymore. But it is still heavily tested. So you do need to know this. Okay. Now, poison by inhalation, again, home medications, that's probably not as common as like inhaling like chlorine from a pool or bleach or ammonia or something like that. Is probably carbon monoxide would be an example, things like that. So poison by inhalation can only occur if poison is present in the atmosphere. So of course, remember on these exams, we're not firefighters. I don't care if you're a firefighter right now. That's great. I appreciate you. But on this exam, you got to turn off your firefighter brain. Okay, turn it off. You're an EMT working for MedStar, right? Or AMR or something like that. You are not a firefighter EMT. So we do not enter hazardous environments ever. Okay, forget that. It's not our job in this capacity. So you call for the specialized resources that have the right PPE. Okay, students will get this wrong constantly because they think that they're firefighters on this exam, and so I can't stress enough. You have to turn that off. It is safety first. Your safety first, always. Now, inhaled toxins reach the alveoli quickly. That's intuitive. So the window for opportunity of treatment is pretty limited. So the first consideration is scene safety, always. So I'll give you an example. You're called, 23-year-old male, unresponsive. You open the garage, he's in the driver's seat of a car with the car running and the doors were closed. What do? You don't go in. The environment it's dangerous. So you don't go in there. Someone else goes in there that has PPE. And you'd be like, well, what about the patient safety? Yeah, that's important, but your safety is more important. So remember, it is always your safety first. And that's not even for books. It's really for the real world. It's your safety first. Don't, the snowball effect. If you go in there and you collapse, it makes it worse. So I'm going to write this down. There's a video that I'm going to share on Canvas for y'all to watch to see this. I'll show you a video, and it'll be one of our discussions, where a state trooper runs in to help this guy who flipped a trailer that was carrying you can see this green gas. I think it's chlorine. And as soon as he goes in there, he immediately collapses the state trooper, and you can hear him die on the thing. You'll hear him take his last breaths. It's very sad to watch, but I think it's important for you to watch, and we'll discuss it in one of our class discussions, because this is what happens. People, they want to help people. We're in the business of helping people, but it's your safety first. All right, moving forward. You would treat hypoxia immediately. What's hypoxia? It means low oxygen in the blood, or low oxygen, really. And so hypoxemia is low oxygen in the blood. And so what we would do is we would remove them from the environment, or someone would remove them from the environment, or the inhalative substance, and then you would provide them with room air. Usually you would actually want to replace it with oxygen. So you'd give them like a non-rebreather at 100%. FiO2. Now, poisoning by injection, obviously, this becomes a problem with fentanyl and heroin, and even people will bump meth and stuff like that. So this creates quite a problem. And so generally, the problem with injection is it's impossible to get it back. When it's been injected, it's not like you can pull on the syringe and get it back. It's gone. And so this is the risk of when we inject medicine as paramedics is like once it's in there, you ain't getting it back. It's gone. And so that's kind of the issue with this. Now it's very rapid when someone injects stuff. This is why they do it. It hits really hard. And so again, this is why they do it. It's not wasted through the GI tract. It's straight into the blood. And so you'll get rapid systemic effects when it's injected, and so that's if you're trying to get high, that's that's the goal. So this is why it's commonly illicit drugs are injected. Now, something to be aware is it can cause tissue destruction. This is more so if they miss. If you go, well, let's say that if you go into the vein, generally you're okay, but these aren't experts on intravenous cannulation. So typically, if they miss, like say you shoot up heroin and you miss the vein and it goes up underneath the skin instead of in the vein, you'll get local tissue destruction and necrosis for sure. So you'll get necrotic. Basically, the skin in that area will get rotten. It'll die. Whoops. Now, poisoning by absorption. The way I want you to know this is it's commonly tested for farm workers. Okay, so fertilizers and organophosphates are very easily travel through the skin by design. And so you'll see that this worker has a mask on, yes, but every bit of his skin is covered, and that's why. Because pesticides and fertilizers and organophosphates, they tend to go straight through they can travel straight through the skin. And so corrosive substances are things like lye, right? Spelled lye, Lye. That'll eat the skin. It's caustic. It's corrosive. It'll chew through the skin. And the mucous membranes or the eyes or whatever, right? Keep in mind absorption. I'm talking mostly through the skin, but you could technically get absorption through the eyes and through the mucous membranes, which would be like your lips, your gums, your stuff like that. It's still technically absorption. It's not ingestion. Now, so you'll distinguish between contact burns and contact absorptions. So, okay, I'll give you an example. If you were to put like a very caustic something on the skin, it would burn the skin, but was some of that absorbed into the systemic vasculature? Perhaps. So you could have both, okay? You could have both absorption that led to a burn. So that a chemical burn, okay? Now, signs and symptoms are history of exposure. Oh, wow. In the vignette, they told you it's a farm worker. They told you it's someone who cleans pools. They told you it's, I don't know, someone working in an industrial factory or something like that. So just be aware of that. Liquid or powder on the patient's skin, burns, itching, irritation, skin redness in light-skinned people, and typical odors of the substance. So chlorine has a very distinct smell. In fact, most bad things have a very distinct smell. This is God's way of saying, of us recognizing, oh, that's bad. So usually bad things smell bad because that's the way that we would know to stay away from it. That's how humans know stay away from chlorine. It's bad for you. So now, again, I said absorption's through the skin, but it can be through the eyes, as I said earlier. And so this is an interesting technique. We'll show you how to do this in class. Someone remind us. Basically, you take an IV bag, and that's a nasal cannula. Okay, so that's like the little nasal cannula that goes in the nose. And what you do is you put it right here on the bridge of the patient's nose, and you have them lay back, and you yank their eyes open, and then you let that water drip down the corners of the eyes, and then across the eyes and down the face. And so there's a really good way to irrigate the eyes. It's very effective. I've actually done this. And it works really well. Patients tolerate it pretty well because we don't have sinks with running water in the back of an ambulance. Now, if they have like an eye wash station in a factory, then yeah, that would be preferred. But this is a good way to do this. So remind us, it's a cool way. It's kind of like some redneck engineering, but it works really well. And so avoid contaminating others. So you'll see questions where they'll say the patient's covered in a white powdery substance. What do? You don't touch them. You have to decontaminate them. Okay, so not you, someone else, a firefighter, is going to decontaminate them. Don't put them in the back of your ambulance. Don't go rubbing up all on them, right? Someone else is going to do that. Remove the substance from the patient. This is usually done in a wafting motion, right, to sweep it off. Especially if it's like gross contamination, you would want to like wipe it off, or not you, someone would wipe it off first. Cut off contaminated clothing. So you'll remove all their clothing first before you typically begin decon all of their clothing. So just be aware of that. And you would brush off, this is what I'm saying, you would brush the powder off. Wash the skin with soap and water. There is like very few substances that will react with water. Sodium, like pure sodium would be an example. That is exceptionally rare, so you don't have to worry about that. Just water, soap and water is your friend, okay? People undervalue the value of soap and water. Wash your hands. It works, right? Like with soap and water, it works. Now, Many drug results and similar to the symptoms. So a toxidrome is a syndrome-like symptoms of a poisonous agent. So like a toxidrome of narcotics, a toxidrome of stimulants, are these like syndrome-like it's like a group of symptoms that presents with them. So you'll hear it like a toxidrome. This is kind of a fancy word you actually don't hear a lot in the field, but you'll see it in books in academia. Okay. Now, here are the major toxidromes, right? Stimulants, we're going to talk about each of these. Opioids, sympathomimetics, sedatives and hypnotics, cholinergics, and anticholinergics. What are those? We're going to talk about it. So, overview of substance abuse. So, it's an area of medicine. It's extremely challenging. God bless substance abuse workers. How difficult that would be. A very needed part of medicine. I could not do it because I'm not patient enough. But um, there's this evolution of substances too that's interesting to mention here. Like man, it's interesting humans' ability to find new substances to abuse and ways to abuse them, and it's just I don't know. But anyways, the substances are evolving, and once we think we figure out like, oh, this is how we treat this, it's like they'll find something else. And so the cultural variation is what is considered substance abuse. I'll give you an example of this. In some cultures, drinking alcohol every day would be considered normal, and in some cultures, it's strictly forbidden. Like a Muslim, right? It's haram, right? It's forbidden. And so this would be an example of like it depends on your culture with what is considered substance abuse. In Western culture, alcohol is pretty well accepted. I'm not saying it's good, but it's well accepted compared to like the Middle East where it's strictly forbidden. Now, society definition may have little relation to potential harm of the substance, and this is it's obvious, right? So just because Muslims don't like alcohol doesn't mean that it's less harmful for Muslims as it is for Westerners. So, or I say Muslims, I'm sorry, it's Arabs. Muslims the religion. I'm sorry, it's Middle Eastern Arab, and so that would be the example. And so the important substance terms. So we'll talk about. I'll actually explain these real quick. These are in our book. These are worth knowing. They show up occasionally on exams. I'll just straight up ask you. What's drug abuse versus habituation? I'm pretty sure I covered this in the pharmacological lecture, but drug abuse is the abuse of a drug. It's to use it outside of its intended purpose. Okay, so it's abuse of a drug. And so habituation is when you have a habit. Cigarettes would be a really good example of this. It's a habit. Tobacco, nicotine, right? It's a habit that has been formed. Now, physical dependence is interesting. You see this with narcotics, especially, more likely benzodiazepines, especially, but it means that their body physically becomes dependent on it, right? They like if they stop using Xanax, they could get sick and have seizures and die. And so their body has it depends on it to function at this point because they have used it for so long. Now, psychological dependence is a little different. An example of this would be like nicotine is probably a better example. Your body doesn't have a physical dependence on nicotine as much as it's a psychological dependence. Yeah, there's a little bit of like physical things that will happen in response to that, but physical is obvious. It's your body physically needs it. Psychological is mental, right? Your mind needs it. Now, tolerance is interesting. So you've probably experienced this when you had your first beer at 21, allegedly. You could probably only have a few beers and get drunk, right? But now that you're 29, um, yeah, it takes a lot more beers for someone that's 29, like myself, to get drunk. And so this is the idea of tolerance, that you build up a tolerance, that it takes more and more of a substance as you're exposed more and more to the substance to get the same therapeutic effect or to get drunk. So you'll see tolerance with opioids and alcohol and really any substance, okay, that's abused. You will get tolerance. In fact, there's very few substances that don't have tolerance, okay. And so this is the idea that like one beer today got you drunk, but if you drink beer every day, a beer this time next year is not going to get you drunk. Okay. Now, withdrawal syndrome. This is when people withdraw. An example of this would be like heroin. They'll get cold sweats and yawning, and they'll get piloerection, which is goosebumps. Irritability, fatigue, runny nose, rhinorrhea. They'll get runny noses. Their eyes will water, stuff like that. So those are all withdrawal symptoms of heroin. The withdrawal of like stimulants like cocaine or Adderall or meth. They tend to have hyperphagia where they eat a bunch and they want to sleep a bunch. Drug addiction, it's kind of obvious, you're addicted to a drug. Now, an antagonist is something that blocks a receptor site. I'll talk about Narcan coming in, but this is a cell. Here's its receptor. There's drugs out there that'll bind to this receptor and block. Let's say this is fentanyl floating in the blood, it can't bind because it's already been the cell receptor's already been bound by the antagonist in this case, which would be like Narcan. And so that's an example of an antagonist. Now, potentiation and synergism are very similar, but basically you could sum both these up to where this I talked about this earlier, 1 + 1 = 4. So I'll give you an example. You take alcohol plus you decide to pop a Xanax, you're going to be a lot more intoxicated versus if you were to take alcohol plus another beer, right? And so that's an example of potentiation. We use this in medicine sometimes to our advantage. If you get I'll just tell you, if you get Benadryl and morphine at the same time, the patient will get really euphoric. And so sometimes we do that on purpose. Now, scene safety, I cannot stress this enough on toxicology ones. Students, it's almost guaranteed on the quiz, you're going to pick one of these that's wrong. So just realize if there's something about safety on there, pick the most safe answer always, okay? Your safety first. Determine the nature of illness, right? How many patients involved? Do you need additional help? Do we need spinal immobilization? Remember, if someone's unconscious, generally you would consider spinal immobilization because we don't know if they fell. Wear the appropriate PPE, and remember that patients may be dangerous, especially patients that are homicidal, suicidal, or inebriated or intoxicated, right? They're unpredictable. So whose safety first? Your safety first. So if at any point you retreat, you retreat. If your safety feels threatened, you leave, you go. And I've done that. I have done that. I have literally said, oh, hey, Denise, let's go out to the ambulance and go get that piece of equipment. Oh, yeah, let's go do that. We're going to be right back, sir. Bye. We're out of there. Left. And then the sheriff's office came, and then we came back. But, you know what I'm saying? Went like straight up abandonment, like we went back to the station and took a nap. But get out of there. Leave. Also, ambulances are pretty fortified. They have locked doors, right? So get out. Like, get in your ambulance, go lock the door. Okay? They're big vehicles, too. It could be like a 15,000-pound weapon. Get out of there. Now, look for clues, medication bottles. So this is where I was talking about. You have to sometimes be a detective. If you get a call, patient's sister came over because the other sister hasn't been answering the phone, and you get called for unresponsive. And so that's all you know. It's just an unresponsive person. But you got to look around the room. Oh, there's a needle sticking out of the lady's arm. Oh, it's probably some type of overdose. Oh, there's pills scattered all across the room. Oh, okay. What's missing? You have to count how many the day is prescribed, how many pills are in there, and how many should still be in there, and the bottle's empty. Stuff like that. So you really have to do a lot of detective work. Look for the unpleasant or odd odors. Look for paraphernalia. Look for alcohol. Sometimes you have to use your sniffer. You got to smell. Oh, it smells like alcohol in here. Alcohol and cat urine. So you're like, oh, okay, yeah, there's alcohol. Like they're drunk. They drink a lot of alcohol. So just be aware. Now, the primary survey, we'll burn through this. It always begins with your general impression. Your general impression is your impression across the room. Oh, okay, wow, we have a lady who's unconscious on the bed, who's snoring. That's your general impression, right? Don't be fooled into thinking that a conscious, alert, and oriented patient is in stable condition. This is why I hate these calls. Because the patient will be talking to you now, and 5 minutes from now, they will be dead. Like I'm telling you, like I hate these calls for that reason, because just because they're good now doesn't mean that 10 minutes from now they're going to die or be really sick. So it's kind of annoying. Now, identify any life threats. Are they bleeding? Are they not breathing? Blah, blah, blah. They have a rope wrapped around their neck, something like that. Are they choking on vomit? Ensure the patient has an open airway. So again, the lady that's snoring, what do? What's your next action? Open her airway, right? Ventilate her if needed. Do not hesitate to begin oxygen therapy. Yeah. Now, assess the circulatory status. This is done through the pulse and the skin condition. Remember, skin turgor is your best, or skin turgor, skin capillary refill. Remember with the nail beds. Very good tool to test perfusion. Use it. Check for bleeding. Assess for disability, right? So alterations in the A, B, C, D, and E's or poor general impression require immediate transport. So if they're not breathing, if they don't have a good airway, if they have exsanguination, if they're disability, whatever, yeah, these are really sick patients. So we immediately need to intervene and transport. Okay, the delay on the scene is rarely indicated. Just go. We're in the business of taking people to the hospital. I'll say that often. Now consider deconning the patient before transporting, depending on the poison. Now again, if they drink alcohol, deconning them is not going to do anything. But if they're covered in fertilizer, yeah, someone needs to decon them first before you put them in the back of a closed ambulance. It's a small space. You're going to be back there with them, so you're going to get exposed. Obtain the patient's OPQRST and sample, right? Unresponsive patient, this again, you're gonna have to use the family, the neighbor, whatever, medical jewelry, cards, patient's wallet, stuff laying around the house, cell phone, whatever. You got to start being a detective. I actually enjoy that, and I think students will too. But sometimes you really got to be we're problem solvers as paramedics and EMTs. So you got to solve problems and figure out what happened. So history taking, and so let me tell you this: when you approach interviewing these patients, you can't cast judgment on them, or else they'll shut down. You're like, "What'd you take? Why'd you take it? How much did you take?" You think they're going to answer you honestly, right? So you're going to show compassion, like, "Okay, sir, we're here to help you, so we can treat you appropriately and get you the best care. What exactly did you take? Okay, when did you take that? How much did you take? Did you eat it? Okay, so you ate it. So and you got to use words like eat. You can't use the word ingest. Um, okay, no, so you injected it, stuff like that. How long have you been doing this? Have you ever done this before? Have you done anything to help? Has any intervention been performed? Has the patient vomited or aspirated? Huge risk with toxicology. Another reason I don't like running these calls is because they can vomit, and if they don't clear it out of their mouth and their airway, they aspirate. So they'll suck it into their trachea and their lungs, and then boom, aspiration. Huge issue when patients aspirate. Okay, it's common. It's a huge. Imagine your stomach contents being shoved into your lungs, right? All that bacteria, all that acid, all that Taco Bell, all those pills, whatever. Now it's in your lungs and your alveoli. So imagine the issues that creates. How much does the patient weigh? Are they like 600 pounds or are they 100 pounds? Do they drink? A 600-pound lady can drink a case of beer versus a 100-pound lady drinking a case of beer. It's different toxidromes. Different issues. You see, I use the word toxidrome. Now, why was the substance taken? This is usually the last question I would ask, um, because it doesn't really change your treatment, other than if they're trying to refuse. So if you stay like, "What'd you take? Would you take it on purpose? Why'd you take it?" Well, then they're gonna shut down. So I'm serious. You got to be careful with interviewing these patients. You got to approach it really delicately. Now, the secondary assessment, this is where we focus on the area of the body involved with the poisoning, the route of exposure. So, if they inhaled chlorine, we'd be interested in their mouth and their nose and their face, their eyes. Manage the life of threats. Okay, obtain a complete set of vital signs. Many poisons reduce no outward indications of the exposure seriousness. Again, these can be over a period of time, and so we need to educate patients on that. They'll be like, "Well, I feel fine." Well, it's like, "Well, you do now, but like this is going to continue. This will progress, especially if it's like an ingestion, if they ate something." Now, look for alterations in the level of consciousness, pulse, respiration, blood pressure, skin, of course. Now, you're going to want to frequently reassess these patients. Don't get caught with your pants down with these patients or sleeping, right? So, what's going to happen is if you'll be like, "Oh, they're fine. I'm just writing my chart," and then you look up and they're snoring, because they vomited. So just you really do want to frequently reassess these patients and keep a close eye on them. Stay engaged with them, talking with them, conversing with them, so you can stay pretty closely connected to their mental status currently. Now remember, this is the algorithm. It's every 15 minutes for a stable patient, and every 5 minutes or more for a patient who has assumed a harmful or lethal substance. Okay, you've seen this in previous chapters. It's 15 for stable, 5 for unstable. Now, estudiantes, I don't want you to be taking a blood pressure every 30 seconds. That's not useful. It's harmful. It's not going to be accurate reading, so don't do that. It's every 5 minutes. Now, the interventions support the ABCs. This is what really probably the greatest intervention you can do. If a patient's not breathing, they're going to die. Dilute airborne exposures with oxygen. So this is intuitive, right? If you have lungs right here, and it's filled with chlorine gas. What you would do is you would want to replace that with oxygen. And so you can it's called washout. You can wash this out if you flood their lungs with like oxygen or something other than the harmful gas. You can get rid of whatever residual gas is in there. So you're going to want to apply high flow oxygen usually if it's inhalation. Now remove contact exposures with water. Consider activated charcoal for ingestion. I'll talk more about that. Continuously monitor the airway and contact medical control and or a poison center to discuss treatment options. Usually you'll have standard treatments, but don't hesitate to contact them for help. Now, once the primary survey, history taking, secondary assessment are complete, you're going to reassess. Contact medical control, I just said that. Report as much information about the poison as possible to the hospital. This is where taking a picture of like a plant or something like that can be really helpful, or taking pictures could be helpful. Now, with that, you don't typically need to take the toxic substance to the hospital. Once it's like pills, that's one thing, but don't be taking no poison ivy plant to the hospital in the ambulance. Like, what are they going to do, right? So just take a picture is usually fine, or a description, okay? If a safety data sheet is immediately available, you should take it with you to the hospital. Again, you'll see that in occupational or industrial exposure, someone working in a factory or a restaurant or something like that. That you have what's called an MSDS, material safety data sheet, and so that you could request that, and it's like a logbook of they're supposed to keep all the toxic or hazardous and toxic substances, like a log of what those are and the treatment for them in a book called the MSDS, material safety data sheet. Now, emergency care, what do? We ensure that they're safe, take standard precautions, perform your external decon in that order, right? Remove tablets or fragments from the patient's mouth. You'll see this. You'll get a vignette where they'll say the patient they're unconscious and vomiting and there's pill fragments in the mouth. What do? Well, you remove them. You suction them from their mouth, okay? With suction, you suction it out. Brush or wash or brush the poison from the patient's skin. So, I mean, think about this too. If someone overdose on, like, I don't know, 20, 30 pills, and they vomit, there's still pill fragments in their intestine, in their duodenum, and in their stomach, to where if they vomit, those will come back up. So you don't want to, like, leave that there. So that's actually common. You'll see pill fragments. Also, let me tell you this. I'm always astounded by the amount of dedication of someone to ingest 100 pills. It's a lot of work, to keep taking that and to not vomit. Because, your stomach's programmed by design to when it tastes, okay, for example, you ever had tequila and immediately wanted to vomit? I have, especially cheap tequila. And it's because my stomach knows, oh God, that's toxic. Ejectocito, cuz. And so it wants you to vomit it. And so it is by design, when your stomach ingests something toxic, it'll try to eject it. It'll try to vomit. But some patients can fight that until they're unconscious, and then your stomach says, aha, now's my chance. And then they'll vomit. And then they aspirate, and it makes everything worse. Now, assess and maintain the patient's ABCs, provide oxygen, and you might have to assist ventilations. It's rather common. Sometimes this can prevent with shock, depending on what they took. And if approved by medical control or local protocol, you're going to give activated charcoal. So activated charcoal, this will show up on a test. Activated charcoal is not indicated for patients who, look guys, I'm even going to highlight it for you, who have ingested an acid, an alkali, or a petroleum product. What does that mean? That means if they tell you the patient drank gasoline, you don't give activated charcoal. If they tell you the patient drank lye, you don't give activated charcoal. If they tell you the patient drank bleach, you don't give activated charcoal. It won't work, okay? And so just be aware of that. Have a decreased level of consciousness and cannot protect their airway, you don't give something by mouth. So think about this. It's intuitive. You're not going to give someone this nasty, thick, black, gross substance to drink if they can't swallow, or if they have a decreased level of consciousness, because what does that mean? They're about to not be able to swallow. And so you don't do that. So just be aware of that. If they can't swallow, if they have a decreased level of consciousness, they can't protect their airway, you don't give activated charcoal. No matter how bad you want to, you don't do it. So don't fall into their tricks on there. They'll be like, well, it's a 12-year-old boy. Help them. Don't fall for it, okay? If they tell you that they have a decreased level of consciousness, they can't protect their airway, difficulty swallowing, do not give activated charcoal. It's the wrong answer. Pick something else. Now, the dose is 1 gram per kilogram. So if you want to know the conversion, you should know this. Let's say it's a 220-pound male, pounds. How do you convert that into kilograms? Well, it's real simple. You divide it by 2.2, and so that equals 100 kilograms. And so a 220-pound man weighs 100 kilograms. So you could take, someone that's 180 pounds, they're going to weigh about 70-something kilograms. So 75, I think. And so that's how you do that math. Divide it, you take the pounds and divide it by 2.2. And so the side effects of activated charcoal is it's going to be black stools, okay? Nausea and vomiting, it's rather unpleasant, and possible airway problems. So imagine aspirating charcoal. It's going to be really bad for the patient if that ends up in their lungs. So the way we would give this when I worked at Cook Children's is we would get like a Coke, like Coca-Cola, Dr. Pepper, Cherry Coke, something that was rather sweet and dark, and we would mix activated charcoal with the Coke to where it would have a little bit of sweet and like bubbles from the flavor of the Coke, and we would put it in a cup to where they couldn't see what they were drinking. And so we'd be like, oh, hey, you should drink this Coke. And so they would drink the Coke, and we would trick them into taking it that way. So that's one way we would do that. Because it is unpleasant. It tastes nasty. It's charcoal. But if you mix it, it doesn't have like a huge taste. But if you mix it with something sweet like Coca-Cola, um, it's tolerable. I've seen little kids that are picky eaters tolerate it. Now, alcohol, okay, most widely abused in the United States and around the world. So, alcoholism is the state of physical and psychological addiction. Alcoholics can have chronic malnutrition. Cannot stress this enough. Alcohol has calories in it, and so like a light beer, not a regular beer, has like 100-ish or more calories in it. And so, if you drink 20 beers a day, that's your calories you need. So they drink their calories, so they tend to be not malnourished. Okay, there's not a lot of nutrition in alcohol. And so they tend to be malnourished, especially like vitamin deficiencies and stuff like that. And so they fall frequently too because they're in stupor. Now, that word, I'm not calling them stupid, it's stupor. Stupor, like they're stupor. And so they fall. And so alcohol causes, and I think I talked about this in neurology, causes what's called truncal ataxia. And so what the interesting thing about alcohol is that your body doesn't know where your trunk is in relation to his extremities. And so this is why alcohol sway side to side at their trunk. It's not their extremities. Their extremities aren't going like this. It's their trunk is moving because they don't know where their trunk is in relation to everything else. And so it causes what's called truncal ataxia. So it's the fourth leading cause of death in the United States. Now, very important to know, alcohol is a powerful CNS depressant, and you hear me talk a lot about this thing called Xanax. It's a very powerful benzodiazepine that's commonly prescribed. Alcohol and benzodiazepines actually work in similar fashions. They work on GABA, and so they're very similar with how they present. So you can get decreased activity and excitement. You could induce sleepiness, okay? Dulls of the sensitive awareness, okay? So you have lack of awareness, especially social awareness. So this is why people misbehave socially, like at the club and stuff, when they're drunk. Okay, you'll have slower reflexes. So again, if you are falling and you're drunk, you may not be quick enough to catch yourself because your reflex to catch yourself has been inhibited, and so you have reduced reaction time as well. So you could see, and we see the mean drunks, right? They get causes of aggression and inappropriate behavior and lack of coordination. Now, the interesting about alcohol is it inhibits inhibition. Like, what? So normally I am inhibited to get up and sing karaoke, right? My brain's like, no, you like to sing in the shower, but not in front of other people. And so I'm inhibited from doing that normally. But if I were to drink a lot of alcohol, right, and I inhibit my inhibition, so I take away my inhibition, right? There's nothing there saying, Hunter, I'm going to inhibit you from singing karaoke tonight if I'm drunk. And so that's why, you drunk people sing karaoke and do stuff they shouldn't do because they inhibit inhibition. A better example of this is someone who makes bad decisions like driving drunk. You know it's a bad idea, but if you have inhibited your inhibition to inhibit you from saying, "Oh, don't do that," people drive drunk, and so that would be a kind of a funny example and a more real example. Drunk driving is not a victimless crime, by the way, and so drunk driving is not a victimless crime. Now, medical problems associated with alcoholism, head trauma, again from frequent falls, toxic reactions. Not only is alcohol itself toxic, it causes toxic reactions to other medications and it damages the liver. Uncontrolled diabetes, alcohol has a lot of calories in it, and also they become malnourished. That's one of the reasons your diabetes will act up because of malnourishment. Death from respiratory depression and or aspiration of vomitus in the stomach contents. Again, we've all been there. Maybe not all of us, but I can't say I've been there, but people have been there when they have drank too much alcohol and they vomit, especially late into drinking a lot of alcohol. Again, their body will say, this is toxic, ejectocito, cuz, and they'll vomit. And so this is the risk. They'll be unconscious and vomit, and that's aspiration. And so that's bad. It's bad when you have all your Bud Light and buffalo wings and pizza sitting in your lungs now. It's a bad thing. Now, physical dependence and withdrawal. So one thing you need to know about withdrawal is there's this thing called delirium tremens. And so what happens is when someone withdraws from alcohol about a day or two, if say you drink every day for a year and you just like, all right, I'm done, I'm going to quit drinking alcohol. That's great. But if you stop what they call cold turkey, that's what the literature calls it, you can get what's called delirium tremens. And this is called DTs. DT. And so what will happen is they'll get tremorous. They'll become tremorous and they'll get real anxious and angry and pissed off. And so what you have to worry about is this will lead to seizures. Okay. And so when you take away this thing called GABA, remember alcohol stimulates GABA. And so their body's like, we don't need to make more GABA because we've been drinking GABA every day for a year. And so when you take away GABA and you're like, all right, I'm done drinking, there's not enough GABA in the blood. So your brain's like, oh, I can't produce enough GABA. And then boom, your brain gets too excited. Electricity starts flying everywhere. You have a seizure. And so these seizures can kill these patients actually. And so it's very sad because what happens is, like, I remember this one guy. I don't know why I remember this call. He's very wealthy, lived on a very nice ranch. He owned a car dealership. And he was an alcoholic, and it was like around Thanksgiving, and his family was there, so he wanted to quit drinking in front of his kids, but he ended up having multiple seizures. So we get the call because he was an alcoholic, and you can't alcoholics can't just, and same thing with people that are addicted to benzodiazepines, because remember they're very similar. They can't just stop drinking. This is why they have to go to rehab and detox, because you have to do this controlled under a doctor's supervision usually, because you'll have seizures. It's really sad. Now, hepatitis is the liver. So the liver is inflamed. Where does the liver sit? Right upper quadrant. And so cirrhosis is scarring of the liver. Okay. So you'll see cirrhosis in late stage alcoholism. Okay. Something I'll say about cirrhosis and hepatitis is the liver produces clotting factors. I'm not making this up. The liver produces clotting factors for blood to clot. And so if patients drink a lot of alcohol and they over a period of time, their liver can get damaged with cirrhosis. And so again, if they fall and whack their head, besides the subdural bleed, which I covered in neurology, they can also bleed a lot. So this is something you have to consider. So there's a general thing. Alcohols fall a lot, they bleed a lot, and they have head bleeds a lot. And it's all related. Now, establish and maintain a patent airway. Suspect internal bleeding if the patient appears to be in shock. Withdrawal symptoms can include seizures. Withdrawal can include seizures, especially 24 hours after the last drink, and call for paramedic backup because, again, they could seize, and EMTs cannot stop seizures. Paramedics can stop seizures with medicine. Now, if a patient exhibits signs of delirium tremens, this is what I was talking about earlier, you want to keep the patient calm. They're usually real irritated when they stop drinking. So don't take anything they say personally, but in fact, they're so irritated, you need to be worried about your safety sometimes. They're very angry and just irritated, and like pissed off. They're just mad. And there's a chemical imbalance, and that's why that's happening. It's not that they're a bad person. It's their brains are messed up currently. They're mentally unwell. And so establish oxygen, establish vascular access, manage hypotension that's intuitive, reassess breath sounds, and maintain a dialogue. So you're going to want to be very kind and compassionate, non-judgmental, of course. Now, opioids, moving on, right? That's alcohol. Opioids, okay? This is a class of medications that are also a central nervous system depressant, but these are pain medicines. They reduce pain. They act on different receptors as alcohol and Xanax. They work on the what's called the MU receptors. And so what happens is you do need to know the differentiation between opiates and opioids. So opiate is a natural drug derived from the opium or poppy plant. And so this is a flower that morphine, in fact, is still derived from opium. And so back in like the early 1900s, people would get high on opium. They would chew on the poppy seeds or like the opium plant itself, the milk from it. And so this you don't see this as often, but opioids are very common now in the United States because they're easier to produce, right? You don't have to grow a plant, you can create them in a lab. And so, examples of opioids would be this. Actually, no, I think this one might be a more derived from opium. I would have to look that one up. It's a pre-pro drug. Heroin, I don't know how that one's made. It doesn't matter. The treatment's the same, but I'm just letting you know. Dextromethorphan, this is a drug for coughing. And so opioids will reduce pain. They also reduce coughing, or they can reduce coughing, the coughing reflex. And so opioids bind with this receptor. I told you it's the mu. My handwriting, the mu receptor. And so you can get this in a lot of different ways. Of course, it can be absorbed through the GI tract, like Vicodin, oxycodone. Through the nasal mucosa, you could certainly, remember the atomized stuff? You could You could shoot this through the nose if you wanted, or snort it, or the lungs, or you could shoot this through the skin, right? This could also be injected as well. Heroin can be injected or smoked. So there's a lot of ways you can do this. And so when heroin passes through the liver, it continues to exert the narcotic effect that may outlast the effects of naloxone. And like, it's out of order. Naloxone is Narcan. That's that drug that's the antagonist to opioids. So this is the antidote. This is how someone overdoses on heroin. You give them this drug called Narcan. You can shoot it up their nose. And so, like in a mist, atomized. And so what happens is you worry about the effect of naloxone, and because like naloxone's half-life's like maybe 30 minutes to an hour, but heroin could be like 4 or 5 hours. And so as soon as the naloxone wears off, boom, they're right back to overdosing. Now, morphine and heroin produce an oppressive dreamlike state, and this dreamlike state can be called euphoria. Euphoria is like a really good feeling. It's being high, okay? And patients chase that, right? They chase that euphoria. Now, the hallmark sign of a narcotic overdose, write this down, is pinpoint pupils. The hallmark of an opioid overdose is pinpoint pupils. So, you have an unconscious patient. You immediately are going to want to look at their eyes. I will yank those puppies open. If their eyes look like that, it's a narcotic overdose until proven otherwise. Okay? Those are very small. It looks like you could take your little pen and boop, it's like a pinpoint on their pupils. Their pupils are very small. Think about this. If your eyes are closed, so there's no light, should your eyes be big or small? They should be big. And so when you pry someone's eye open who's unconscious and they look like that, that's telling you their parasympathetic nervous system is overactivated, usually by opioids, and they have pinpoint pupils. So watch for that on exams. Pinpoint pupils equals opioid overdose. Okay? Now, with opioid use features, again, euphoria. Euphoria is a really good feeling called like being high. Hypotension, low blood pressure, respiratory depression, pinpoint pupils, vomiting, constipation, and coma. Now, constipation is interesting. If someone takes opioids for a long period of time, they'll get constipated. Like not even a long period of time, 3 or 4 days, you can get constipated. And so it's something to consider when you have someone who's taking opioids who has abdominal pain. Especially if the abdomen's hard. You would ask them, when's the last time you pooped? Oh, it's been 10 days? Yeah, okay. You're probably constipated. That's where your pain's coming from. So let's talk about, this is off the AHA's algorithm. How do we treat this? So you're going to check for responsiveness. Again, you're going to look in the pupils. If they're pinpoint, right? You're thinking narcotic overdose. Shout for help, right? Get help. Sometimes you are the help. You're 911. Activate the emergency response systems. Again, you are 911. Get naloxone and an AED if possible. Now, again, naloxone is sold over the counter. We're going to talk about this more coming up. Now, is the person breathing normally? No. Does the patient have a pulse? If they're not, you're going to start CPR. Okay? Patients that aren't breathing or don't have a pulse, CPR. But if they're breathing abnormally, but they do have a pulse, you're going to open their airway and you're going to ventilate them. And then you're going to give them naloxone, which is Narcan. Okay? Now, if the patient's breathing normally, you're going to open the airway and reposition. You're going to consider giving them Narcan, and I'll talk more about this, and transport them to the hospital. You're going to continuously reassess them and use this algorithm. Okay, it's very intuitive with this algorithm, but you must know this. Now, is Narcan naloxone indicated for someone that is talking like I am, but they told you, oh, I took 2 oxycodone just now? Do we give them Narcan now? No, we really don't. We only give Narcan or naloxone. They're the same thing. Narcan's the trade name. We only give naloxone when we have respiratory or airway concern or compromise. Okay, so again, Narcan's not used as a punitive punishment to take away someone's high. Okay, in fact, if you take away their high, they can become very aggressive and try to fight you. So you use it carefully. Okay, it's usually for respiratory compromise. Now, Narcan reverses the effect of an overdose, opioid overdose, okay? And it can be administered through the IV, intramuscular, you can give it like a shot, or intranasally. We've talked about the intranasal route. Now, acute opioid reversal can lead to vomiting. This is something you really got to worry about. If you give a bunch of Narcan to someone, you have to worry about like true projectile vomiting, like shooting ambulance up to the roof of the ceiling, like big vomiting, okay? So be careful. Now, remember that patients could have a mixed bag overdose, so did they take alcohol and oxycodone and Xanax? Who knows? So you have to be aware they can have more than one toxidrome. They can have more than one toxic substance, okay? You could take those pills and bottles to the hospital. That's helpful, but we don't take plants and animals to the hospitals, okay? Like, you don't take a poisonous snake to the hospital. Report findings to receive personnel and illicit substances to uh, law enforcement. Now, again, you don't want to be a snitch and be like, how do I say this right? Okay. You don't want to violate the patient's trust in you. Okay. Now, usually, if it's an overdose, law enforcement will be called before you got there, and they'll make the scene clear and safe before you even go in. But sometimes you don't know that, and so you don't want to be like, I'm gonna call the cops on you, right? You don't be like that, but oh, the cops showed up. Oh, they show up to all our calls. They're just here. They're just here to make sure everything's good, right? And you might tell them in private, but you don't want to violate your patient's trust, is what I'm saying. But it doesn't need to report it. It doesn't need to be reported, but you don't want to like make it too obvious to where you violate your patient's trust or make them angry with you or snitch on them. Now, stimulants. Um, Stimulants, these are common, especially in it's in everyone really, but swallowed, smoked, IV injection, okay? And so you can imagine if I were to stimulate you, what would happen, right? And so these tend to be sympathomimetic to where they work on the sympathetic nervous system to make that work a little bit harder. So again, you can almost imagine, well, if you're going to fight a bear, right? A lot of adrenaline. That's in essence what cocaine, methamphetamine, Adderall. That's what they're doing. They're stimulating those similar hormones and receptors and pathways. And so you can get excitement and delirium, um, tachycardia, hyper or hypotension with a rapid fast pulse. So what's a fast pulse? What's the word for fast heart rate? Tachycardia. Dilated pupils. So the pupils will be big. Because again, if you're going to fight a bear, you want all the light or just a little light? You want all the light. So you'll get dilated pupils from the sympathetic nervous system activation. Tremors and seizures. This is probably more rare. I would say it can happen, especially with a large overdose, but it does. What would be more likely is hyperthermia. They'll be sweaty. They'll be all hot. Now, cocaine, derived from a plant. Okay, lots of it's very, obviously you've seen this in Hollywood. It's in the movies. Usually snorted. I do want you to know that it's through the mucosal membranes. Okay, and so there's also like in a club where they don't want to like have like you know uh, booger sugar on their nose. What they'll do, like cocaine on their nose, what they'll do is they'll rub it on their gums. So you'll see like people in the club like rubbing their gums, and they're not brushing their teeth, they're rubbing cocaine on their gums. And so because it absorbs quickly through the mucosa. And so cocaine's actually a very powerful CNS stimulant. It's a stimulant, true stimulant. It's also a local anesthetic. What does that mean? It reduces pain. So if you were to snort cocaine, it would make your nose numb, right? Because it's a CNS or it's a local anesthetic. And so actually, ENT, ear, nose, and throat doctors use cocaine like in surgery because it causes vasoconstriction so they don't bleed, and it's also an anesthetic. So it actually has a legit medicinal use, and it's actually used in surgery. Now, when the effects wear off, the users will experience a crash. This is obvious, right? So they'll be very tired. They'll want to eat a lot because their sympathetic system was so stimulated. You can imagine what happens when that goes back down. The parasympathetic will be like, it's time to rest and digest. So they're going to want to eat and eat, rest and eat. So cocaine washout syndrome, I don't know what that is. Now, amphetamines, there's several legitimate applications of amphetamine, right? Like Adderall. Ritalin's not amphetamine. It acts very similar, though. Um, even like ephedrine. And that's what they're showing you here. Ephedrine, phenylephrine, right? These drugs have a legit use. And so even methamphetamine. Methamphetamine's it's a prescribed drug for weight loss and narcolepsy. It's called digoxin. And so these have legit uses, but obviously they're very easy to abuse. Because think about the reason for abuse of this. If someone said, oh, well, I'll give you a drug like Adderall. I'll give you a drug that makes you focus, that gives you energy, that makes you lose weight, and that makes you feel good, right? It's pretty enticing for people to want to abuse that. And so it's actually the abuse of amphetamines is getting really high now that this is being prescribed online, which I think is dangerous and reckless. But it is being prescribed online right now because of COVID. There was a waiver that was lifted. And so just be aware it's becoming a public health problem that people are using amphetamine. And these drugs, they have very legitimate medical uses for like narcolepsy and weight loss and ADHD and ADD and runny nose and stuff like that. Uh, they're abusing it. Now, the signs and symptoms of a stimulant abuse is wild-eyed, so they'll have like real big eyes. They'll usually be really thin. The reason that is because stimulants like cocaine and amphetamine, they tend to, again, they're elevating the sympathetic nervous system. So the parasympathetic nervous system that's telling you, hey, it's time to eat, is being suppressed a little bit. It's being overridden by the amphetamine. And so they tend to not eat because they're not hungry, because that part of their nervous system is being turned off a little bit. Nervous or jittery, inadequate nutrition or sleep, and increased paranoia. Paranoia is this feeling of worryingness, and so like you're excessively worried about something that may not be real. Okay, so like you could be paranoid of the government or paranoid of aliens or something like that. Now, complications associated with cocaine use, and really Adderall, or I keep saying Adderall, amphetamines, is cardiac dysrhythmias. So again, you can stimulate the sympathetic nervous system so high that it'll increase the heart rate to where they'll get tachycardia and all these tachyarrhythmias. And so you have to worry about that. Acute myocardial infarction. These can cause coronary artery vasospasm, and so the muscle or the vessels that feed the heart muscle itself, the myocardium, can spasm. And so when they spasm, that can cause a heart attack. And so cocaine is known to do that actually. And so seizures, stroke, apnea, the lack of breathing, that's not as common, but it could happen. That'd be very late, very rare. But hyperthermia, I alluded to this earlier. A lot of times these people run hot, right? Like they're physically hot because again, their sympathetic nervous system is ready to fight a bear, so it's running on full drive. So they're running really hot. Now, the treatment for a stimulant overdose for an EMT, it's limited. For paramedics, we give them drugs like Xanax. We give them GABA, right, to calm them down. But what we're going to do as EMTs is we maintain maximum oxygen saturation level, of course, prevent seizures with sedation if needed. And again, we don't do that as EMTs. Whoops, I forgot to take that out. And so monitor the vital signs closely, establish IV access, and manage their low blood pressure, apply a pulse ox, and you might want to consider paramedic backup on these because again, these patients can deteriorate. One thing I'll say is you need to be very careful. These patients can become very aggressive. All these patients, all these toxidromes, they can become aggressive, and so just be careful. Marijuana or cannabis compounds. This is a little marijuana bud. Let me tell you this: marijuana is illegal federally. Okay, not my opinion. It's a class 2 controlled substance. But there's a lot of states. Texas is actually one of them. This video is recorded in 2024. You can get prescribed marijuana in Texas now if you have an incurable neurological disorder. And so, let me tell you this. The marijuana is actually a very commonly accepted slang of the actual drug itself is called cannabis. Okay, so do know that cannabis is marijuana or weed or whatever. And so marijuana can cause slight bronchodilation. You're like, well, that's weird. Smoking something causes bronchodilation and slight tachycardia. Let me say this. Marijuana, of all the things that I've talked about today, is probably the safest one. Very rarely have I had to run a call on someone who smoked real marijuana, not synthetic stuff like K2 or Spice. We'll talk about those. But real marijuana is pretty safe, whatever. So anyways, euphoria, which is a feeling of feeling good, drowsiness, diminished motor coordination. So again, you wouldn't want to operate heavy equipment or vehicles when high on marijuana or intoxicated by marijuana. Bloodshot eyes, this is the hallmark. So you'll see these guys will put like drops in their eyes to reduce the bloodshots. Like their eyes, bloodshot is like red eyes where you can see the vessels. So let's just focus on supportive care. Now, with that, spice is incredibly bad. Incredibly bad. Back in like 2016, 17, 15, when this was legal and you could buy this in a gas station, we used to run these people all the time. And it would wreck people. It would mess them up. I mean, like some of the worst toxicology calls I've ran were these. And so I'll give you an example. There was a kid in Alito in a gated neighborhood. He decided to smoke some of this, and so he broke into his neighbor's house and got naked and was laying in his neighbor's master bed, like yelling. And so the neighbor's like having dinner. And he's like, "Who's yelling in our bedroom?" So he goes in there with a shotgun and almost kills this kid. Like, 'cause he's like, who's the naked kid on my bed? And so when I say kid, he's like 17, 18. And so, the kid was that lost, that intoxicated. And so this is it's not as easy to get in the United States anymore. They've made it to where it's illegal. It's pretty big. This is a felony to possess this now compared to marijuana. It's a misdemeanor. And so in Texas. And so depending on the amount. And so this is just something to be aware of. The spice stuff is super bad. Oh, and it's called synthetic cannabinoids. And so the reason they call it spice is because they were marketing it as like, oh, it's just like a spice. It's an incense you would burn to scent your room, like skunky poop, like marijuana. And so, that's what it was marketed as. And same thing with like bath salts. People weren't dumping half a gram of bath salts into their bath; they were snorting it. And so, you don't see this as much anymore, but it's certainly still out there. A lot of people did this once and were like, "Yeah, that's not for me," because it's not a good trip. Not a good trip. Now, hallucinogens, this is a class of medications. These magic mushrooms are a real thing. These are becoming very popular all of a sudden, like even like with house moms and stuff. And so, um, you know, they're hallucinogenic. So LSD is the classic one. Psilocybin mushrooms, this is the magic mushrooms that you are seeing. Phencyclidine, like also known as PCP, is a very scary drug because something I want you to know is it gives you superhuman strength. So you've seen the videos on cops and stuff where like the guy's naked in the street and he's running and it takes like literally 10 cops to put him in handcuffs because they have superhuman strength. And so you have to be concerned about that. Ketamine, you'll see this as well. Same mescaline, these are similar. These are drugs, ketamine we carry on the ambulance for legitimate medical purposes, but you can get this in veterinary medicine and like vets use this, veterinarians, and so it can be abused, and so it'll create, alteration. So hallucinogenics cause you to hallucinate, an alteration of reality, and so that's what they do. Now, treatment is primarily supportive on these. You might have to worry about airway stuff if they're unconscious or they have. These can depress people, especially in overdose scenarios. It can be a CNS depressant where it takes them down, and so you have to worry about um, uh, like airway compromise and them not breathing enough, so hypoventilation. And so you have to be careful with that. So you just have to monitor them. It's pretty standard care. Now, sedatives and hypnotics are in a different class. So that's hallucinogenics, cause you to hallucinate. And some people like that. But sedatives and hypnotics, these are barbiturates and benzodiazepines. So barbiturates, the example you would want to know for that is like the phenobarbital. And benzodiazepine, this is that one. These tend to end in am. So like lorazepam, clonazepam, midazolam, it's different, diazepam, stuff like that. So they end up usually in like PAM or LAM. And so these drugs act on GABA. The exact mechanism varies between the two, and so that's what the risk is. We don't see phenobarbital used very commonly in the United States anymore, but it is used very commonly in other parts of the world because it's cheap. And so the risk of overdose of phenobarbital is very, very high, and I'll draw this out real quick. So if you overdose on like lorazepam, right? This is lorazepam, right? It tends to mellow out, but the problem with if you overdose on phenobarbital is to the moon, and so it never stops. So you never get this plateau of suppression of the CNS, and so this is a very dangerous drug. Actually, yeah, it is. It's a very dangerous drug, and that's why it's not used very commonly because the risk of overdose is so high. So anyways, the treatment, airway management is the first priority. You really have to worry about, again, their airway, their respiratory drive will get knocked down, so they'll be hypoventilating. So watching the vignette, they'll tell you, patients breathing 10 times a minute, but shallow. Is that okay? Okay, I'll give you a better example. They're breathing 12 times a minute, but shallow. Is that okay? No, it's not. You need to ventilate them. So watch out. They'll tell you they're breathing 12 times a minute, and you're like, oh, that's normal. But it's not when they add the word and shallow. They need ventilatory support. Call for paramedic backup, establish IV access, right? And so activated charcoal is an option for this if they injected it, or if they ingested it, if they swallowed it, you can use activated charcoal. Cardiac meds, I won't spend a lot of time on this because you don't need to know exactly how these work, but this is where your iPhone is a good friend and can be like, well, what is carvedilol, what is, amiodarone, what is digoxin, these drugs that you would want to look up and be like, oh, that's a cardiac drug that's used to treat. Okay, I'll give you an example. Someone overdoses on lisinopril. Okay, you would look that up and you'd be like, oh, that's an ACE inhibitor that's used to treat hypertension. So what do you think is going to happen if you take a drug that's used to treat hypertension? You take too much of it, you're going to have low blood pressure. So that's that. So use your phone to be a detective. Okay. Now, a lot of times these are accidental, but sometimes people will take these intentional to try to harm themselves. Now, signs of the overdose, it depends on what they took, right? They could have hypo or hypertension, usually hypo in cardiac drugs. Weakness or confusion, rhythm disturbances, nausea, vomiting, headache, difficulty breathing, you name it. Now, again, this is going to be very similar. Supportive care. It's supportive care for these patients. Take them to the hospital. Okay. Now, some of these drugs, the cardiac drugs, have antidotes. Like digoxin has an antidote, and so like metoprolol, labetalol, carvedilol, there's an antidote for these. And so, antidote is like the drug to fix the overdose. And so, you want to be careful with that. If there's an antidote, you want to know what they took so the doctors or the paramedics can give the antidote. Now, these are just a few other medications. We'll burn through these pretty quick. They're rather intuitive, but erectile dysfunction drugs like Viagra, Cialis, these can cause hypotension. These are phosphodiesterase inhibitors, and so basically, you got to worry if someone's like they got drugged or they're like, oh, well, I can't get an erection if I take one, so I'm gonna take five, and so I want a really good erection, so they'll take five, and they'll overdose, and so that's how these happen, and so just be aware. Now, TCAs, these are a terrible thing to overdose on. These are called tricyclic antidepressants. Trazodone would be an example. Um, Amitriptyline, stuff like that. And so basically, they aren't prescribed very often because the overdose for these are so incredibly fatal and like terrible for patients to. It's not like a good way to die, but you will die, and so you'll die pretty quickly. But it's a bad way, and so we don't prescribe these as often if we can help it because of the risk of overdose. And so what's interesting is these are psych drugs, and so if you give a patient with psychotic history, they're statistically at a higher risk of suicide. And so you gotta that's the thing when you prescribe psychiatric medications is like, oh well, am I giving them a very easy or effective way to kill themselves by prescribing this? And so you gotta be careful with that. And so like for example, trazodone, a TCA, they'll be like, oh well, trazodone's used to help you sleep, and so they'll be like, oh well, I'm gonna take all of my trazodone, so I want to sleep and never come back. And so actually, you get this terrible toxidrome when you take this. Anyways, you get what I'm saying. It's a bad thing to overdose on. Now, there's these things. It's kind of surprised they wanted you to know this, but you could know it. Called monoamine oxidase inhibitors (MAOIs), and so basically these are drugs that are used to treat Parkinsonism, and they reduce the breakdown of amines. And so amines are like dopamine. Okay, so this is a drug that prevents the breakdown of dopamine. Okay, and so patients that have Parkinson's don't have enough dopamine, so we give them a drug that allows them to have more dopamine because it's not broken down. Well, interestingly, there's this emergency that can happen, and the patients are educated on this. But if they take monoamine oxidase inhibitors like selegiline, is the drug's called selegiline, and so if they take that and they drink wine and cheese and like cured meats, that's what this picture is down here. Those meats contain it's preserved foods, naturally preserved foods like wine and cheese and meat. It has this stuff called tyramine in it, and tyramine will cause this hypertensive crisis if you take that with a monoamine oxidase inhibitors like selegiline. And so just be aware of that. It's kind of rare. Patients know not to take wine and cheese and meat when they're taking this medication. They're educated on that, but it happens. People do crazy stuff. Now, SSRIs, I put a few this is a picture I put on here. These are like, you don't need to know these names, but you'll hear them commonly, like Wellbutrin, Lexapro, Zoloft, Effexor, Paxil. Those are the trade names of these drugs. They are used to treat depression. And so what happens is, again, these patients are depressed and they're like, oh, my Zoloft makes me feel better, so I'm gonna take 20 of them. And so they take 20 of them and then they overdose on them. And then so you get this toxidrome of, symptoms include nausea, vomiting, dysrhythmia, sedation, tremors, agitation, high blood. You can get blood pressure changes either way, really, seizures and hallucinations. And so what these are doing is these are increasing serotonin in the synapse. And so remember, the synapse is the space between nerve cells. And so it's like, okay, well, we'll just increase the amount of serotonin there. We know serotonin can make people happy. And if we make people happy, they're less depressed. So that's the idea behind these drugs. And so, the care is, standard care, right? Establish, maintain the airway, high flow oxygen. Someone you might consider calling for paramedic help to establish vascular access. This picture's too big. I don't know what happened. Now, this is a drug called lithium. Lithium's used in bipolar disorder. And so bipolar disorder is when someone is manic, they're like super manic, very high grandiosity, making bad decisions, followed by a pretty quick episode of depression. And so that's a very simple way to explain bipolar disorder. And so what we found is we give them lithium. It's a really effective way to treat this. And so watch for that in the vignette. If they say they have a history of bipolar, you should know lithium's the first line drug. Problem with lithium is it has a very narrow therapeutic index. What does that mean? The difference between, this is really therapeutical and helpful, and that's way too much and now it's toxic, is very thin, right? And so a little change in the dose can be too much. And so that's just what I would want to say about that. And so what you have to worry about is if someone overdoses on this, they'll get nausea, vomiting, they'll get tremors. Yeah, that's important to know. Tremors, excessive thirst, and slurred speech. They'll also usually urinate a lot. They could urinate a lot. This is a form of nephrogenic diabetes insipidus. Excuse me. And so, again, maintain the airway. All these are going to be the same. Maintain the airway, supportive care. NSAIDs, drugs of this class you've taken before: ibuprofen, naproxen, meloxicam, Toradol, those drugs, Midol, those drugs. They're very effective drugs, so don't be disillusioned by the fact that they're over the counter. They're still very effective drugs. And so if someone takes these for a long term, you actually have to worry about stomach ulcers and gastritis. It's one thing to know. But if they overdose on them acutely, aspirin is another example of this, by the way. If they overdose on them acutely, you can get headache changes, altered mentation, behavioral changes. They can get real aggressive. Seizures, bradyarrhythmias, hypotension, abdominal pain, nausea, and vomiting. They can also get something called synchronism, which is ringing in the ears with a headache. And so it's usually supportive care. This can be lethal, but it's not easy compared to Tylenol. It's not as likely you'll die. We can treat this with some stuff. Now, salicylate, this is aspirin, by the way. Salicylate is aspirin. And so, there's not really an antidote to salicylic acid. And so this is just, you have to be aware that you could overdose on salicylic, like aspirin, and you could have what's called metabolic alkalosis. That's a concern. Metabolic alkalosis with this. Because, what am I doing? It's acidosis. I'm sorry, take that back. Cut. It's metabolic acidosis from overdosing on this. Why is that? Because the word acid's in the name of the drug. So if you ingest a lot of it, it's in your metabolism. And now you have metabolic acidosis. Now, acetaminophen, the interesting dose, I think it takes about 1 gram per kilogram, or it's 1 gram per pound. It's a lot for the lethal dose, but this kills your liver. And so what happens is the patient will be like, I'm going to take my pain away, so I'm going to take 100 Tylenol. And so this will kill you, but it takes about a week or two because it kills your liver. And so it'll kill your liver, and so you die of liver failure a few weeks or a month later. And so it's a terrible way to die. And so, this is where activated charcoal would be a really good indication because this would be one of the treatments, but there's also an antidote called acetylcysteine. And so there is an antidote to Tylenol, but, and I'll just tell you, you don't need to know this, but let me explain it because it's kind of interesting. Tylenol itself is not toxic. It's the byproduct of Tylenol metabolism that is very toxic to the liver. And so what we do is we give this stuff that helps fight that byproduct of metabolism of Tylenol. So that's kind of how that works. So GHB, this is tested often, but you don't see this often in the streets anymore. It's a very expensive drug, and it's prescribed to patients who have narcolepsy disorder. So it immediately puts people to sleep. Okay. And so it's the one where they'll pour it in their drink and like just a little bit, boom, they're unconscious. And so this is gamma hydroxybutyrate. And so be careful. Sometimes you'll see that on the exam where they write out gamma hydroxybutyrate. And you're like, what's that? It's GHB. And so this is a date rape drug. And so it's usually used for sexual assaults and to facilitate sexual assaults. And it's because very little of it in a drink will render someone unconscious. And so, this is why you don't take a drink from someone that you didn't see the bartender make it himself. And so this has produced a pronounced hypnotic effect. It makes you very sleepy and disinhibition, severe passivity, so you'll kind of like go with the flow, and integrate amnesia, which means you won't remember the events going forward. And so the idea, this is why it's used, is because if someone were to date rape you with this and put this in your drink at 9 o'clock, you're not going to remember the events from 9:15 forward. And so you don't know what happened. You don't know who raped you because you don't. It's called an integrate amnesia. Amnesia means to not be able to remember, and so antegrade means going forward. Amnesia, you're not going to remember anything going forward from this, as long as the drug's in your system. And so, you have to worry about CNS depression. I've actually seen this at Larry Joe Taylor. Saw a lady got GHB'd once. We ended up intubating her, putting a tube in her throat to help her breathe. She was really sick. And so just be aware. It's very sad as an 18-year-old girl. I think she may have died because she was hypoxic when we found her. So what's unfortunate is they'll rape them and leave them, of course, and they're not gonna like nurse them back to health, and so they'll leave them. And then she was like not breathing well, and she aspirated as well, and so I think she got date raped. Very sad. Now, organophosphates, I've alluded to these. These are drugs that are used as insecticides. They can also be used in warfare, like nerve agents. We don't use this. We're not supposed to use these anymore, but there's been speculations these were used in the Iraqi war. Saddam Hussein was allegedly using these in Libya, So, anyways, they're used occasionally, and so often exposure comes from agriculture accidents or suicide attempts. Okay, I actually had a professor. This is odd. That was from India, and he told me that his thesis, his PhD publication, was in the risk. Apparently, it's very common in the rural Indian communities. They'll overdose on organophosphates, on insecticides intentionally. It's how they overdose, to where they now lock up the organophosphates to prevent people from overdosing intentionally. So that's kind of interesting. Now, the signs and symptoms of an organophosphate overdose is very, very obvious, and it's called there's mnemonics, and I meant to put a picture in here of sludgem and dumbbells, what these mnemonics mean, but you must know one of these. Okay, really, for now in the book you need to know both of them, but you actually see these, and so you can see. I'll tell you what these are. So salivation, lacrimation, urination, defecation, gastroemesis upset, and meiosis. And so what you'll see is salivation is like spit in the mouth, lacrimation is runny, like watering eyes, urination, peeing, defecation, pooping, gastroemesis upset, obvious, and meiosis is pinpoint pupils. This overstimulates the parasympathetic nervous system. And so if you get lost on an exam, you could be like, okay, well, what would happen if I overstimulated the parasympathetic nervous system? Your GI tract, right? Your mouth and your eye. Well, your eye's kind of different, but your mouth and your urination and defecation in your GI system is going to be in overdrive. So that's where you get the majority of these symptoms. Okay. I don't remember what dumbbell stands for anymore. I don't use that mnemonic. I use sludgem. You can look it up though. Almost done, guys. I know this is a long one. So decontaminate the patient before continuing. Call high flow oxygen, maintain the airway, use pulse oximetry. End-tidal CO2 would be a good tool for this patient as well. 11 end-tidal CO2. Transport immediately. You might want to call for paramedic help. There is an antidote to this that's carried on the ambulance. It's called atropine, and so we can give an antidote to this. Okay, and there's another one, 2-PAM chloride peroxidine, that could also be used for this as well. So there are antidotes to this. So again, this is where paramedic backup becomes kind of helpful. But you as the EMT needs to spot it and recognize that this is an overdose. Now, carbon monoxide, I've talked about this before, but carbon monoxide is the byproduct of incomplete combustion. So a car engine or a house fire or a campfire or a water heater or a gas stove or whatever. The byproduct of that is carbon monoxide, CO. Do not confuse this with CO2. CO2, carbon dioxide, is what you're breathing out. That's the byproduct of cellular respiration. Not the same. Carbon monoxide, CO, is the byproduct of combustion. And so The problem with carbon monoxide is it is odorless, colorless, and tasteless gas. You can't smell it, can't taste it, right? You don't know. And so here, let me draw this out. Here's your red blood cell, okay? Well, normally, if these are little oxygen boys, you can carry about 4 oxygen on a normal red blood cell, okay? But what happens is when you have CO, let's say CO are these green guys, these bind to oxygen very, very, very aggressively, around 260 times more aggressively than oxygen. So what will happen is they bind to the oxygen, and then the oxygen is truly fully saturated. It's just saturated with carbon monoxide. And so it binds 262 times easier to the hemoglobin than oxygen. So what happens is you end up displacing oxygen and it'll bind to CO. Well, then you end up with hypoxemia, right? And so this is why you'll get I've talked about this before, but this is very important and commonly tested. This is why if you put them on end-tidal CO2, it'll read 99%, 100%. And you're like, oh, their skin's red. One of the signs and symptoms of carbon monoxide is what they call cherry red skin. You'd be like, their skin's red. They have great cap refill, and they're 99% on room air. There's nothing wrong with their oxygen. No, 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 no. What pulse oximetry is measuring is saturation of hemoglobin. What it is saturated by, it does not know. It is typically oxygen, right? That's what normally happens. But if carbon monoxide has been introduced, then it will be bound 100%. It's just bound 100% by carbon monoxide. It's not bound by oxygen. And so this is where you'll get what's called a falsely high, very important. You'll get a falsely high pulse oximetry reading. Very, very important. You will be tested on this, I promise. Now, with that, a common way this is done if people want to commit suicide is they'll like run a water hose up into the car, turn the car on, close the garage door, and let it run. It's a pretty quick way to die. Very effective way to die. You die from hypoxemia. And so you'll become unconscious and then you'll die. And so you got to be careful with that. So watch for that with vignettes. Remember, these patients aren't safe. You know, I've even seen them do test questions before where they'll say the car's turned off, but there's a water hose from the exhaust pipe run up into the driver's side window. What do? You don't do anything, right? You evacuate, you retreat. And you're like, well, Hunter, the car's not even running. Well, there's still carbon monoxide concentrated inside the vehicle. And so, again, you call for help. So watch out for vignettes on that. This could also happen. Another common way this will happen, an unintentional way this will happen, is in like a space heater in a house. So I've actually ran this before where the space heater in the house wasn't vented properly. And so the husband and wife were both had carbon monoxide poisoning. So you want to be careful with carbon monoxide poisoning. If you have a bunch of people in a house that have cherry red skin and shortness of breath and, you know, altered mental status and reading 100% on room air on the pulse oximetry, and it's like the first cold day of the month or of the year, you need to think, oh, this is carbon monoxide overdose. So watch out for that. You need to retreat the scene and get to safety. Now, remove the patient from the exposure environment, not you, someone else needs to. Establish and maintain the airway. Administer high flow oxygen. Again, this is a washout thing where you're going to want to apply high flow oxygen to try to wash out the CO that is in their lungs and blood. And so the treatment for this is actually high flow oxygen. Now, you could do hyperbaric oxygen therapy where you put them in like a tank with really high flow oxygen, like in a hospital, like a specialized hospital. But really, you don't see that very often. What's more common is we'll put a non-breather on the patient for 4 hours and redraw their blood. That's how we do that. Now, keep patient quiet. You don't want to exacerbate this, and I think they're probably talking like you don't want them to blow it off, which I think is silly. But monitor level of consciousness, transport to an appropriate facility. Some of them will have hyperbaric chambers. It's very rare. Parkland in Dallas is the only one that I know that has a hyperbaric chamber available for this. And consider the possibility of combined carbon monoxide and cyanide poisoning. Cyanide is the byproduct of combustion of inorganic materials, carpet, couches, fur, stuff like that, like, clothes, upholstery. That will produce this stuff called cyanide. And so, I tell you, student, you have a patient who's found dead inside a house fire, laying on the floor. He's burnt to a crisp. What do you think killed him first? Do you think it was the burns from the heat? Do you think it was the carbon monoxide or the cyanide poisoning? It was probably cyanide poisoning if it's inside a house first that killed them. So remember the whole electron transport chain thing? Remember where we get all these ATP created? Cyanide turns that off. So when you turn off the thing in the body that creates ATP, you die very quickly. Okay? Metals like lead, you don't see this very often, but you can see this in older houses that were used with lead paint. You might see this in a vignette with someone that uses like ammunition a lot. So older ammunition used to have actual lead in it, stuff like that. So industrial exposures, again, someone that works in a factory. But lead causes it's a heavy metal poisoning, and so you can get you can delay intellectual development in children with this. And then so the half life in bone is 30 years. In fact, there's a really cool X-ray, so I meant to put it on here, where they'll shoot an X-ray and there's these lines in the X-ray, and that's lead that is deposited in their bones, and so you can see if someone's been chronically exposed to lead by an X-ray. And so the treatment options in the field are very limited, and so you take them to hospital, right? And so just be aware of that. Iron, you'll get GI toxicity. There's not much you can do for iron toxicity. This is kind of rare, but one thing I'll say about iron toxicity is kids vitamins that are tasty, like really good. Almost everything in there, if they were to take 100 of them, is fine. Generally speaking, it's not ideal, but it's fine, with the exception of iron. Iron can be, if you truly overdose on it, it can be really bad. So typically, if a kid overdoses on like Flintstone gummy sours, which I take myself, delicious, highly recommend. You really, what you worry about is the fact of the iron. The iron is the one where like, oh God, we got to figure out what's up with the iron. We got to watch them because we're worried about the iron. Chlorine gas, again, just using pools. It's going to create a burning sensation. You get chemical burns. We'll talk about this in trauma. You can get chemical burns in the nose, mouth, eyes. You can get chemical burns with chlorine gas. Cyanide, I talked about this. Remember, cyanide is the byproduct of combustion of inorganic materials like upholstery. And so you'll get, it doesn't take a lot to for someone to die with this. This is used in assassinations often because you can ingest it or inhale it. And so, or inject it or whatever. And so it turns off the electron transport chain. So it's a very quick way to die. Caustics, again, these are going to be things like lye, Lye. And so you'll use these in like industrial accidents, industrial stuff like that. And so this will burn straight through the skin. Methyl alcohol and ethylene glycol, these are important, and where you'll see these is antifreeze. And so antifreeze, so I'm told, has a sweet taste to it. So you'll see like it's very lethal for dogs, but like children will like drink antifreeze for whatever reason because it's like a really cool color. It looks cool. It's green or blue, and so they'll drink it. And it has ethylene glycol on it, and so it tastes sweet, and so they'll drink quite a bit of it. And this can be very fatal because actually what happens is these transfer into the blood for formaldehyde. I misspelled that. Formaldehyde. And you're like, I've heard of formaldehyde. What is that? That's what we use to embalm dead bodies and cadavers. And so you can imagine that floating around your blood, very toxic. So they'll end up with like it's just toxic. You can die from this. It also destroys your kidneys. Special methyl alcohol. So there's a plastic company in Weatherford that like I guess employs halfway house people. So this guy was like a recovering alcoholic, and so they use methyl alcohol, which is not ethanol. It's different. And so this guy, in a lapse of judgment, drank a whole bottle of it. So then he like started vomiting. We get the call. So I'm like, all right, whatever. He's drunk. He's acting drunk. So we take him to the hospital and we immediately get a transfer to Fort Worth. And so we go back over there and the doctor's like, oh, he needs to go for immediate dialysis. He definitely has destroyed his kidney and he'll probably need dialysis for the rest of his life. And so, it's one thing to know these destroy your kidneys. Hydrocarbons, these are the other things that will result from burning of really any materials. So it could be wood or even inorganic material, but this is household products, right? And so this is toxic. That's really what we need to know about that. So when you hear hydrocarbons, actually, yeah, I think hydrocarbons too would be considered like a gasoline and stuff like that, if I remember right. Food poisoning. Now you would see this in a vignette when they say like you're at a camp out, you're outside, it's a nice day out, and suddenly 10 people start complaining of vomiting and diarrhea and whatever. Um, the most common culprit, so you know, is actually is cream-based substances like mayonnaise and stuff like that. So watch out, Staph aureus will grow on that, and so is that's not kept at the proper temperature. Staph aureus will grow, and so it creates very rapid onset food poisoning. It's not lethal usually, but just something to know. So watch out at those campouts for mayonnaise containing products. Now, there's way more than four pathogens, but the major ones I want you to know for whatever reason: salmonella, toxoplasma, listeria, norovirus. There's way more than that you can get food poisoning from. But those are some major ones. This is a mixture of viruses, protozoas, and bacteria. So the signs and symptoms could take several hours or several weeks. It depends on what it was. It could take even a month if you talk like trichinella and stuff like that. Or not trichinella. Yeah, trichinella. And so there's like ones that will grow in your muscle and all these other issues you can get. So just be aware, food poisoning, we've all been there. Supportive care. Supportive care. Now, poisonous plants, last few slides. There aren't that many plants that are truly poisonous. There are certainly a lot of plants that are irritating, but death is fairly rare. But beneficendaceae, I probably am saying that wrong, but especially I've heard of the castor bean. Castor bean, if you ever watch Breaking Bad, right? That's how they're creating ricin to kill people, and I think they even use it on Better Call Saul. But you can extract a very toxic poison from castor beans. And so these are castor beans, by the way, and they actually use these in the movie or in the series. And so I don't know what all these are, so I'm not going to act like I do, but these are apparently poisonous plants. So with that, that's all I have for this lecture. Appreciate y'all's time. Thanks.